in this technical similar to lumbar. Please remember 7 minutes from the oral communication to keep on time.
Thank you everybody and for invitation, and my congratulations from Ukraine, from independent country, and I would like to thanks for my teacher Dr. Park and Dr. Sond for possibility to share my experience in UBE. My experience was from 2019. It's about 6 years, but today I want to speak about the cervical spine UBE. This presentation completely based on my own experience. My experience not very big, but it's about 20 patients a year. That's why cervical UBE is this technique similar to lumbar UBE or not? A lot of endoscopic surgeons consider cervical UBE as incredibly dangerous and complicated procedure. They consider the lumbar UBE like driving a family car, but cervical UBE like flying a fighter jet. The relative frequency of cervical UBE surgeries in the total amount of all UBE surgeries is not more than 5–7%. That's why very often we try to avoid and to stay calm and not nervous. That's why we very often prefer to visit a funny movie, but not want to visit a very serious movie. Sometimes after performing 20–30 lumbar UBE cases, a surgeon suddenly decided he's ready for cervical UBE, but he keep in his hand just a lumbar UBE license. But after unsuccessful result of severe complications, they will try to avoid the surgery in the future and share incorrect information about impossibility of this technique, and we save by the lumbar UBE license parachute. The most important mistake in complete assessment of the main differences between cervical and lumbar UBE, incorrect imagination with cervical and lumbar UBE the same technique. We have to completely understand the difference between cervical and lumbar UBE, like a difference between anatomy of flight jet and family car. This is the most important key anatomical differences in cervical UBE. First of all, we have to remember about the skin, subcutaneous tissue, and nuchal ligaments problem. They were very thick and hard. It's not comfortable to insert serial dilators, high possibility of unexpected perforation, and high risk of lamina damaging. That's why sometimes we unexpected surprised about suddenly perforation of ligamentum nucha and damaging of the neural structure. What the decision? Decision is strongly preoperative design and prediction the depth of incision. I suggest to every time use a needle using anti-arm control before dilators. More wider using of scalpel of the subcutaneous tissue to make more space for dilator. We have to completely predict the depth of our needle because it completely depends on the depth of our working instrument. In this case, we start from the using the needle, control on the lateral view, and only after that I suggest to use the working instrument. Bifurcation of spinous process problem: not clear bony image under the arm and AP viewer, hard navigation, and high risk of lateral deviation. Decision: try to make true view on AP, always check device position on lateral view to avoid the perforation of lamina. Relatively short spinous process problem: deficit of working space for bilateral decompression. We can't use the interlaminar approach like we use it on the thoracical spine. Instead of, we have to use floating approach and to make the spinous process floating. Relatively thin lamina problem: in case of using target point like in lumbar UBE, easy to penetrate the serial dilators and possible to cord damage. Instead of, it's my suggestion not to use this point, but to use this point. Non-aimed membrana. It's very difficult sometimes to recognize and completely understand the difference between the membrana, non-aimed membrana, and can you? Yes. Play the movie, please. Can you play the movie? Because the difference is very important for avoid the damaging of neural structure. Because sometimes we surprised after cutting after removing the, as we think what is it is the nerve root, but after removing the nerve root and cutting the as we imagination what this is the disc space, but suddenly we perforate and damage the neural structure. That's why we have to very politely, very gentle separate the non-aimed membrana to have a good recognizing of all neural structures. Cord level, it's very easy to perforate the neural structure and of course the ligamentum flavum by using the serial dilator. As you can see in this picture is my own experience. This is the perforation of dura, and after I recognized this complication, I was very afraid because I don't know about condition of neural structure. That's why, play the movie please. Play the movie. That's why what's problem? Problem high risk of neurological deficit by additional compression by instruments which are usually used on lumbar level. Decision, no cord compression technique, carries some limitation using high speed drill with diamond bore, elevation, no compression technique, need to use hemostatic sponge or wax instead of radiofrequency because it's, and that's why it's my suggestion to use the high speed drill and diamond bore to completely and generally recognize the non-aimed membrana and to make the movement not from outside to inside, but inside to outside. The next problem, landmarks. In UBE surgery, is very important to completely understand where you are. That's why you have to find your stars on the sky, to have imagination about your next performing. That's why we have two landmarks. The first landmark is the V point, which is situated on the angle between the lower and upper lung. Okay, sorry. And the second landmark is we have to find the V point. After that, we of course have to find the inner V point to have a good decompression in foraminal stenosis. And in this case, we will be successful and everything will be good. And thank you for your attention. And if you have a good crew, you will be successful and your landing will be very successful also. And I ask only 1 minute. In my native city, Kam'янець-Подільський in Ukraine, in end of May, will be very great event. It will be a ESUBE course, and I invite all of you to my native country, to Ukraine. Don't be afraid. This is the average schedule of power supply in Ukraine. As you can see, the white point, this is the time of power supply. It's usually about 4 or 5 hours a day. But we are still working, we are still living, we are still fighting, and that's why I want to thank to all European community for support our country, for support Ukraine, and I am sure that everything will be good. Thank you so much.